Okay, so exam questions, diabetes. A 15-year-old boy is admitted in a comatose state. His mother stated that he had complained of extensive thirst from about a week previously. She thought he had lost weight over the past few weeks. On the day of her admission, he had vomited repeatedly and become drowsy. On examination, he was comatose with deep and rapid breathing. Breath smelled of acetone. Signs of dehydration were present. Loss of skin, turgor, dry mouth, sunken eyes. Pulse is 110, BP 90 over 50, dipstick urine. On urine showed glucose 3 positive, ketone 4 positive, pH 5, plasma sodium 130. You can see that is low. Potassium is 5.8, that is high. Chloride is 100, which is normal. Urea is 18. Creatinine is 140. Glucose is 32. pH is 7.05. Partial pressure of carbon dioxide is 2, which is low. Bicarbonate is 5, which is low. What type of acid base disturbance is present here? So when we are looking at the acid base disturbances, the very first thing that you do is to look at the pH. So by looking at the pH, is this acidosis or alkalosis? Anyone to help us? It's acidosis. So now, since we know it is acidosis, there are two possible things that can cause acidosis. It's either there is a gain in acid or a loss in base. So those are the two things that you are looking at. If you have got low base, it means that the cause is because of that. If you have got high acid, it means that that's the cause. Now, there are actually two things that you can look at there. You can look at carbon dioxide or bicarbonate. So, what we are saying is this is acidosis. So, we are saying that acidosis can be caused by high acid. And when we are saying high acid, what are we trying to say? We can look at the respiratory system and the metabolism part, which is the kidney. So it can either, if we have got high partial pressure of carbon dioxide, it means that this is going to be respiratory acidosis. But if we have got low bicarbonate, then this is metabolic acidosis. We are not looking at hydrogen because hydrogen is normally not given. Otherwise, this is going to correlate. If we have got high hydrogen, that's the same. But hydrogen is not given here. So let's look at bicarbonate carbon dioxide. So if you look at bicarbonate, bicarbonate is 5. That is low. So this is telling us that this is a metabolic condition. So this is metabolic acidosis. Because if you look at carbon dioxide is supposed to be high. But this carbon dioxide is also low. It's 2. So why is carbon dioxide low? Because I've got metabolic acidosis, I'll be trying to breathe out fast, right? I'm trying to breathe out fast so that I can remove excess carbon dioxide, which is acid. So that is actually the low carbon dioxide is representing respiratory compensation. But look at the pH. The normal pH is 7.35 to 7.45, and this is 7.05. So it's not too close to the normal. So there's just partial compensation. So this is metabolic acidosis with partial respiratory compensation. Hope that's okay. The second part is saying calculate the anion gap and comment on its value. How do we calculate the anion gap? Anyone to help us? Actually, when you just say a question where they're asking about anion gap, just know there is metabolic acidosis because that's why we apply the anion gap in metabolic acidosis. So anion gap is given by sodium plus potassium minus bicarbonate plus chloride. Sometimes we just use sodium alone, so just a sodium plus bicarbonate minus plus chloride. So the sodium here is 130 minus bicarbonate. We don't use the standard bicarbonate, we use the actual bicarbonate. So if they've given you SBC, you don't use that, you use bicarbonate itself, which is a 5 here, plus chloride is 100. So this is going to give us 25. The normal is 10 to 20, so this is high. So comment on its value, it is high. And when you're talking about the causes of metabolic acidosis, look at the anion gap is something like this. Look at this gamma table, very simple, like that. This region is representing positive things, okay, positive things. And then the other one down will represent negative things. So there is the major negative thing is actually going to be chloride, which is negative. So acidosis can be caused by gain of positive things or loss. And anion gap is just a region, this region here, that has not been compensated. Because when you get positive things, you remove negative things. The law of nature is that it's supposed to give you zero. But look, if I get positive things, I subtract negative things, I've not gotten a zero, I've gotten 25. Meaning that there is this region here that has not been cancelled. That hasn't cancelled the positive region here. That's the meaning of an ion gap. Okay, the excess anions that we don't know. So what happens that when we are gaining, because in acidosis, it's either we are gaining positive things or we are losing, right? We are losing base. So what happens if I lose base? Let's say, for example, I lose by this was the region of bicarbonate. If I lose bicarbonate, what happens that chlorine is another negative things and bicarbonate was negative. Chlorine will take up that space where bicarbonate has been lost. So the loss of bicarbonate correlates to increase in chlorine. So that's known as hyperchloremia. Okay, hyperchloremic or so if we calculate the anion gap in that case, what will happen is that we are basically going to have a normal range here. If you have got a gain in hydrogens, you are gaining what you are subtracting from, right? You are gaining more positive things. So gain in hydrogen correlates to high anion gap. But loss in base, there is no change in anion gap because the negative that you've lost has been replaced by the chlorine. So that is normal anion gap. It's also known as hyperchloremia. So normal anion gap or hyperchloremia is caused by gain of base, while high anion gap is caused by loss of base, while anion gap is caused by gain of acid. Okay, and here we have calculated high anion gap. It means that we have gained acid, and that correlates to diabetic ketoacidosis being described here, because diabetic ketoacidosis is gain in acid, right? What is or are the likely reasons for the elevated urea and creatinine? Anyone that wants to help there? Why is there elevated urea and creatinine? Okay, so urea can accumulate because remember this is diabetes, right? The body doesn't is thinking there is not enough glucose. So what happens is that the body will start making glucose from other mechanism like gluconeogenesis. And as you are making that glucose from gluconeogenesis, you are also going to be producing urea. So urea is going to be high because of gluconeogenesis. Besides that, when urea is high, There's also a condition known as pre-renal failure. So it can also be that there's pre-renal failure. That's why there's urea being high. And then creatinine tells us the renal function. So if creatinine is high, it means that it is not being removed, it is not being absorbed on the glomerulus, because almost the entire creatinine produced is supposed to go here. So if it is high in blood, it means that there is low glomerular filtration rate. So that's the meaning of high creatinine. What treatment is appropriate? So we already talked about the treatment for diabetic ketoacidosis or even metabolic acidosis. One thing you want to do is to be able to give insulin therapy. After giving insulin therapy, we said every time you give insulin therapy, always think of replacing potassium, right? Because we said that there's going to be hypokalemia that will develop. Beside that, you can also give isotonic sodium chloride, which is the normal saline. You'll give it together with 5% of dextrose, as we already described. What biochemical parameters should be frequently monitored? So in this condition, make sure that you are frequently looking at potassium because it can be a bit dangerous. You are also looking at the sodium. You're also looking at the glucose. Besides that, the urea and the creatinine, which are also telling you about the kidney a bit. And you are also looking at the acid base. So you are going to be looking at the pH. How is the pH changing? So those are things you can be looking at. Why is potassium slightly increased? Do you think it may change during treatment? So remember, potassium is slightly increased because when you have got acidosis, hydrogen is going to be displacing the potassium from the inside of the cell, so to go outside the cell. Because of that, it is going to increase. Okay. Do you expect it to change during treatment? Yes. Why? Because as you give treatment, as you give insulin, there's going to be like you are stopping the production of the ketone bodies. So since you are stopping the production of acid, what will happen is that the potassium will start going back into the cell. So it has changed. And then why is the sodium low? Does it necessarily imply sodium depletion? This is no, because in diabetes, sodium is going to appear low because when sugar is high, what happens is that water starts to end to go a lot of it into the blood vessel. So there's dilution happening. So because of that dilution, it means that sodium will appear low because you are looking at it. Let's say you have got two people in a very big house. It might look too big to them, right? Too big to them. But let's say, for example, you bring 10 people. The same house will appear small. It's just because of the pool that you're talking about. So when you increase the water content, sodium appears to be low. So because of the dilution effect, there's an increase, there's expansion of ECF because of the glucose that is attracting water. The bicarbonate is low. Should it be corrected with sodium bicarbonate? And this one we already answered, isn't it? Don't correct it with sodium bicarbonate. Why? Because immediately you give insulin, the sodium, the immediately you give insulin, the pH itself will be corrected. The pH will be corrected itself, as we did explain earlier. How is it being corrected? Because when you give insulin, there's a correction of the acidosis. You're not producing ketone bodies anymore. If you end up giving the sodium bicarbonate, it might switch off the respiratory drive, it might worsen the acidosis, and those are the reasons we gave. What type of diabetes is likely here? We said diabetic ketoacidosis is a complication of type 1 diabetes. So that is type 1 diabetes. Hope that is okay with this one. Number 2, a middle-aged widow living alone was found semi-conscious by her son. He had last seen her a week before. when she had seemed well. On examination, she was extremely dehydrated but not ketotic. Respiration was normal. She was not a non diabetic. Treated with fluid and insulin. We can see sodium is before treatment, sodium was 148. After treatment, it became 160. Potassium was 4.6. After treatment, it dropped. Bicarbonate was 18. After treatment, it became 23. Chloride was 118. After treatment, 130. Total protein 90 to 76. Osmolarity 380 to 350. Glucose 54 to 12. Ketones were not there before and after treatment. Urea was 30 and after treatment is 12. What is the diagnosis? Anyone that has got a thought, what would you say is the diagnosis here? So remember, we've been told that she seemed well, she's semi-conscious, she's dehydrated, but non-ketotic. So you can think of, and she's being treated with insulin, meaning that she has diabetes. So what complication of diabetes is this? Okay, she was she was not a non she is not a non-diabetic actually, but she's being treated by insulin, meaning that she has got some high levels of glucose. So what complication is this? Yes, so there is a hyperglycemic hyperosmolar coma or hyperglycemic non-ketotic coma. Hong. What is the cause of this coma? So the cause of hyperglycemic hyperosmolar coma is because to the brain there is actually dehydration. So there is cerebral dehydration. Why did the sodium rise after treatment? Can you predict how much the sodium will rise from the measured 4 in glucose? So the glucose had to drop from 54 to 12. How well does this agree with the actual increase in sodium? So the first, why did the sodium rise after treatment? So what happens is that when you start treating, remember someone has got high sugar, glucose will start entering the cell. And as get at as glucose is entering the cell, water also start moving with it going into the cell. So sodium in that case will rise, right? It will rise. Why is it rising? Because you are reducing the ECF volume where glucose is. Okay. So since and actually what is happening here is that sodium will rise by 3 millimoles for every 10 millimole for in glucose. So when glucose changes from 50 to 40, like let's say in ECF it was 50 and then it became 40, sodium is going to rise by 3. So when you look at the change that has been given here from 54 to 12, the difference is going to be 42. So that 42, what we are trying to do is, because the second part of the question is asking what to be, how, uh, what to be the rise. Can you predict how much the sodium will rise from the 4 in glucose? So the 4 from 54 to 12, if you subtract, that is going to give us what? A 42, right? This is a 4. That's a difference. We are saying that for every change of glucose, for every 10 millimole change, sodium is going to increase by 3. So what you simply do is get this number 42 and multiply by 3 out of 10 to give you the increase in sodium, and that is going to be 12.6. Okay. And then the next part of the question is saying, do you think the dehydration was more severe in this case than the previous one, case 1? Why? So there's a comparison. But I don't want to answer this part because the other case that we are referring to here is the one on top that we've answered. But anyway, sodium and glucose are appreciably high. So you are going to just compare the values for the first case and the second case. So for the second case, the sodium values, the glucose values are high. So you expect that yes, even the dehydration is going to be more severe. Comment on the total protein. You can see the total protein was 90. After treatment, it became 76. Okay, so what is happening? Anyone that wants to say something there? Why do you think there is that change that is happening? There is a drop in the total proteins. So because when you treat, the ECF volume is decreasing. What is going to happen is that there is going to be increase in hematocrit and total protein because the ECF volume has increased. Okay. Why is it important in this case to lower the extracellular osmolarity slowly? Why should we lower the ECF concentration slowly? And we said that is to prevent cerebral edema. Shouldn't do it very quick. So we want to prevent edema of the brain. Why is a fall in serum potassium less impressive than that usually observed during treatment of ketoacidosis? These questions are tiresome. So why is the fall in serum potassium less impressive than those usually observed during treatment of ketoacidosis? So here in uh, in this condition, there is less acidosis. So because of less acidosis in comparison to diabetic ketoacidosis, there's going to be less hydrogen to be able to displace potassium from the inside of the cell. And so there's no sudden increase in pH to cause potassium influx. Hope you get that. Why is a fall in serum potassium less? It's because there is less acidosis. If there was more, it means there would be more of the potassium being displaced. What is the appropriate continuation therapy after you get to treat here? What you want to give is half of the normal saline or 5% glucose to lower the sodium and then to be able to refill the ECF. So want to give this normal saline. Is there an acid-base disturbance present? If so, how may it have arisen? So in this condition, this is honk. Of course, you expect there to be metabolic acidosis because of some renal impairment. You see, when we are treating, the urea improved, the creatinine improved. That is telling us that there was some form of renal impairment or lactic acidosis. So that is that. The last question: you are the new doctor in town, and on your first call day, 55-year-old woman presents to the emergency room. On examination, you note that she has a low Glasgow Coma scale and a thread pulse. She appears jaundiced, multiple spider nevia are present on her trunk, and she has massive ascites. Her JVP is raised. Husband tells you that she has been a heavy drinker with poor dietary habits, and she had previously had liver trouble. She had begun to vomit blood the previous day. Blood was taken for emergency investigations, which showed the following results: renal function test, sodium is low, potassium is normal, urea is high, creatinine is high, glucose is low, ammonia is very high. pH is 7.54, partial pressure of carbon dioxide 6.54, SBC, which is bicarbonate, standard bicarbonate, is 35, which is high. Liver function test, the total protein is normal. Albumin is low. Total bilirubin is high. Conjugated bilirubin is high. ALT, liver enzyme, there is high. Phosphate is high. In other words, liver enzymes elevated. So number one, give three likely causes of the patient's low GCS, the Glasgow Coma Scale. Now, the Glasgow Coma Scale, if it is low, it means that the patient might be unconscious, and things that can cause unconsciousness, you can see from the data that we have. There, look at ammonia. Ammonia is high. So what happens, and you can see there is elevated liver enzymes. So if they are elevated in liver enzymes, means that there is a problem in the liver. So the liver can't conjugate ammonia. Ammonia is supposed to be converted to the less toxic form. So since the liver can't do that, the ammonia will accumulate in the brain, and that causes what is known as hepatic encephalopathy. So that is the first thing. Hepatic encephalopathy can lead to low Glasgow coma scales. And when you look at glucose here, glucose is low. Hypoglycemia is one that can cause a low glycemic scale. And also electrolyte imbalance. You can see there is hyponatremia, there is hypokalemia. So those things are also contributing to the low Glasgow coma scale. Number B, what acid-base disturbance has this patient developed, and what is the most likely cause? If you look at pH, it's here, 7.45. That's alkalosis, isn't it? But you want to see the cause of the alkalosis. You are looking at carbon dioxide and bicarbonate. Alkalosis, bicarbonate, if it is high, then it is metabolic. Carbon dioxide, if it is low, then it is respiratory. So let's look at carbon dioxide. Carbon dioxide is high. So this means that's not respiratory. Bicarbonate is also high. So bicarbonate being high, this means it's metabolic. So this is actually metabolic acidosis with respiratory composition. The normal is pH is 7.35 to 7.45. So there's some composition because of the drop, because of the rise in carbon dioxide that we've seen. So it's metabolic alkalosis with partial respiratory composition. And then what what is the most likely cause? What is the cause of this problem? Vomiting is one cause that can lead to this. Actually, when you look at chloride, because chloride is what tells you about if the cause is vomiting or not. Do we even have the chloride concentration? Okay, if the chloride is not given, you can look at the history. She had all this husband, heavy smoker, had liver disease, began to vomit blood. So vomiting is one cause of alkalosis because you are losing hydrogen. So that is that. And then what is the most likely explanation for why the total protein remains normal despite low levels of albumin? You can see here proteins are normal, albumin is low. And the thing there is because what happens is that albumin is low because it's produced by the liver, and we have just seen that the liver is failing. So then the next thing is that antibodies will start to accumulate, the globulins will start to accumulate. In chronic liver disease, the liver's ability to produce albumin is impaired, that's why it's low. But the immune system is going to take up the lead by producing the globulins, and those globulins are the ones that are going to maintain the normal protein level because the total protein is a combination of all these. What life-threatening complication may arise in this patient because of ascites. So ascites, the biggest complication of ascites is these blood vessels of the abdomen, okay, being big. So the biggest complication of ascites is actually what is known as spontaneous bacterial peritonitis. There is inflammation of the peritoneum because of bacterial infection. What underlying cardiac pathology might have developed in this patient? Now, for patients that are taking alcohol, cardiac pathologies, we call them cardiomyopathies. For people that take alcohol, they can suffer in what is known as di- uh, alcoholic cardiomyopathy, which is actually a type of dilated cardiomyopathy. Actually, dilated cardiomyopathy can be caused by alcohol intake sometimes. You also have what is known as hypertrophic cardiomyopathy, but that one they are going to describe a story where someone is maybe playing football and then they just fall there and then because there is a rest to breathing and then they die. So here it is alcoholic or dilated cardiomyopathy. What X-ray finding would support your answer? If you have this cardiomyopathy, there's going to be cardiomegaly. The heart is going to be big on X-ray, so that can support our answer. So that is it for this class. Thank you so much for being present.